Thank you so much. It's really a pleasure to be here and have the opportunity to talk with you this afternoon. Is the volume okay? Perfect. All right, is that better? Yeah. So I want to talk with you this afternoon about cancer. And when you think about priorities in global health, cancer really isn't usually one of the things that comes to the top of the list first. But cancer kills 30% of our population, and I think of it as a major public health problem, both for rich countries and for poor countries alike. And when we look at the number of deaths due to cancer, you can see that the number of deaths due to cancer each year globally is greater than the sum of deaths due to TB, malaria, and HIV/AIDS. And I think it's particularly concerning for people in the developing world when you look at projections for the increase in the number of new cancer cases. Really, the developing world is going to see the vast majority of this increase in incidence. So it's a problem that is important today and will become more important as we go forward. I want to begin by talking about cervical cancer. Cervical cancer is a huge problem globally, particularly in sub-Saharan Africa, where it is the most common cancer diagnosed in women. And it's also the leading cause of cancer death for women in sub-Saharan Africa. Globally, there are more than 500,000 new cases of cervical cancer every year, and more than 275,000 women die every year from cervical cancer. And over 85% of those deaths occur in the developing world. And the real tragedy is that all of those deaths are preventable. It's been estimated that fewer than 5% of women who live in sub-Saharan Africa have the opportunity for a cervical cancer screening exam even one time in their life. Now, my lab is very interested in cervical cancer, and we do a lot of work in Malawi. My work in Malawi has previously been related to pediatric technologies, but a couple of years ago, when I was visiting a district hospital in Malawi, this is widely considered to be the best district hospital in the country. I was talking with my friend Alex Ngwande, who heads their community health outreach program, and I was talking with him about our lab's interest in cervical cancer and how I wanted to start a program in collaboration with his hospital, and I wanted to get his ideas about what their needs were around the problem of cervical cancer. And he got very excited. He said, you know, we have many, many women in our catchment area who suffer from cervical cancer, and there's definitely a problem that you can help us with. And he pulled out this bottle that you see here in these little dosing cups, and he said, our home-based care team, we have so many women who have end-stage cervical cancer, and they're receiving liquid morphine when the home-based care team visits them for palliation. And we're really concerned that they're not getting the proper dose of liquid morphine. So we'd like you to help us figure out how we can more accurately dose morphine for palliation. And unfortunately, that is a sad reality for cervical cancer throughout much of sub-Saharan Africa, is that our approach has been, how do we provide palliation for women who have stage 4 cervical cancer? We would really like to think about how can we offer prevention instead of focusing on morphine for palliation. So the situation that Alex and the women that he and his team are taking care of is really particularly tragic for 3 reasons. And the first is that cervical cancer is preventable. We can eliminate mortality. We can even eliminate incidence. This graph shows 5-year survival rates for cancer patients, 3 organ sites that I'll talk about this afternoon: the cervix, the oral cavity, and the esophagus. And if you look at the 5-year survival rate for patients who are diagnosed at a stage when they already have a distant metastasis, you can see for all these organ sites, the survival rates are very, very low for patients who are diagnosed at a late stage. In contrast, if they're diagnosed when their cancer is still confined to the organ site where it originated, 5-year survival rates are much higher. And if we can identify and treat precancerous lesions, then we can, in fact, prevent people from developing cancer in these organ sites. We know who to screen and we know how to screen them. That's the other reason that it's tragic. This is a picture I took at an HIV/AIDS clinic in Swaziland. And Swaziland is a country that has the highest prevalence of HIV in the world. This is a group who is particularly at risk, women who are immunosuppressed because of HIV, much more likely to have persistent HPV infections that lead to cervical cancer. You can see a bunch of posters on the wall behind these women, and one of the posters is this one right here. It says, "Attention women attending an HIV/ARV clinic, have you had a pap smear done in the last year?" It goes on to explain why it's so important to have pap smears for cervical cancer screening. So I asked a nurse at this clinic how many pap smears they performed annually. Did they have any kind of cervical cancer screening program? And they don't do any pap smears here. They have no cervical cancer screening program. So despite the fact that they are seeing the population at risk, there's no screening available there. And the final reason that I think the situation is so tragic is that cervical cancer screening is very cost effective. This is data from Sue Goldie. It's a little bit of a complicated graph, but I want to walk you through it. If you look on the y-axis, we've got the percent that you can reduce a woman's lifetime risk of developing cervical cancer. And on the x-axis, we've got the dollars that we spend screening her during her lifetime. And so as we spend more money, we can reduce more her lifetime risk of developing cervical cancer. And each of those dots there represents a different strategy for screening and doing that in a different setting. So you can see as we spend more money, we eventually reach a point of diminishing returns. And that's where we in the United States sit. And you can ask the question, if I'm sitting up here in the United States and I invest an additional $50,000 into cervical cancer screening programs, how many years of life, how much life can I buy with that $50,000 investment? And when you sit up here at the point of diminishing returns, the answer is about 15 weeks of additional life. And we judge this actually to be a good investment of resources. But if you ask that same question down here in South Africa, where you can go from offering no screening at all to offering a once lifetime screening at age 35, and you invest your same $50,000 in doing that, the amount of life that you can buy with your $50,000 is 1,000 years of life. It's a very different return on the investment. So why do we even need new technologies for cervical cancer screening if what we have already is effective? Well, we know it's not being used. Now, what happens in the developed world to screen for cervical cancer is women have pap smears, cytologic test. We look for abnormalities in the exfoliated cells from the cervix. And then if we see abnormalities, they return for a visual examination of the cervix, usually done through a low-power microscope called a colposcope. We biopsy it. If the biopsy shows high-grade precancer, then women are treated with a therapy basically where we remove the epithelium of the cervix. It's done as an outpatient therapy with local anesthetic. Fertility is preserved. Very, very effective. But in most of the developing world, all of the infrastructure for doing this just doesn't exist. Now, what people are looking at to provide cervical cancer screening in these settings where the resources are not in place for cytologic exams, for colposcopy, and for biopsy is a pretty simple idea, two technologies. One is called visual inspection with acetic acid, or VIA. And in a VIA test, what you do is you put a speculum in so that the provider can visualize the cervix. They splash acetic acid, a weak solution of acetic acid, onto the cervix. And any area that turns white, you can see a whitish lesion right here. Any area that turns white is presumed to have a precancerous lesion in it. And then if there are aceto-white lesions, women are treated. VIA is very simple. All it takes is a trained provider and vinegar and a speculum. You have to have the electrosurgical excision procedure then to treat, but it's quite possible to implement this in very rural settings. The challenge with visual inspection with acetic acid is that while it is relatively sensitive, while it is good at finding disease, it actually has pretty poor specificity. And somewhere between a half and a third of all the things that turn aceto-white are really just benign changes. And in this particular aceto-white lesion, it was biopsied, and the result of the biopsy is here, and it just shows benign changes. It doesn't show any precancerous lesion at all. These are data from a recent review that look at the sensitivity and the specificity of VIA over here. And you can see that the specificity ranges from a low of about 50%, that means 1 out of every 2 lesions is a false positive, to a high of the mid-80s. So with VIA, you end up over-treating a lot of women. And that drives the cost of the procedure. And if we can avoid overtreatment, it's obviously good to avoid overtreatment. Other people are looking at HPV DNA testing as a tool to improve cervical cancer screening. And there are now some good HPV DNA tests that are available. VIA costs about $5 a test. The HPV DNA tests right now are about $8 a test. And HPV DNA testing has some of the same issues with poor specificity because just because you are HPV high-risk positive does not necessarily mean that you will develop a precancerous lesion. So the gold standard really for diagnosing these precancerous lesions is to look at a biopsy of the tissue and look for changes in the morphology of the cells and the architecture of how those cells are arranged in the epithelium. And predominantly what pathologists are looking at is they're looking at the size of the nucleus and the ratio of the nuclear size to the size of the whole cell, the nuclear to cytoplasmic ratio. And as we move from normal epithelium over here on the left to a high-grade precancer over here on the right, we see cells with larger nuclei, cells with larger nuclear to cytoplasmic ratio. So if we don't have the infrastructure in place to do cytology and look at cytologic smears under the microscope, take biopsies and look at those biopsies under the microscope, can we instead develop microscopes that will enable us to look directly at the changes in nuclear size and nuclear to cytoplasmic ratio without ever having to remove the tissue, and do that in real time and do that at the point of care? That was the project that we began a few years ago, was to try and develop a high-resolution imaging system that could be used by nurses at the point of care to get that same information that you would traditionally get from a biopsy, but do it without all of the infrastructure that you need to take and analyze those biopsies. Now, there are a lot of confocal microscopy approaches that will allow you to do optical sectioning to get beautiful images of nuclear to cytoplasmic ratio and optically thick tissues. But confocal microscopes are obviously very bulky, very expensive, not very practical for trying to image cervical epithelium in places like Swaziland or Malawi. And so instead we developed what we call a high-resolution microendoscope. It's a battery-powered microscope. It's shown here. It's about 12 inches by 12 inches across. It uses a $10 LED as the light source, and it runs for about 8 hours on a laptop battery. There is a fiber optic bundle. You can see the fiber right here. It's about 1 millimeter in diameter, and you can place it in contact with the cervix, or you can put it through a biopsy channel in an endoscope. And there's a CCD camera in the microscope, and that allows you to visualize the cells that are in contact with the distal tip of that fiber probe with subcellular resolution. And so this is an image of epithelium. The field of view here is about 750 microns. This microscope works in fluorescence mode, and we use actually an antiseptic called proflavin to stain the nuclei so that they are very brightly fluorescent. And one application of proflavin costs less than 1 cent, so it's a very, very inexpensive dye. It has a long history of safe clinical use. So we've carried out 2 clinical trials with this device, one in Botswana and one in China. And I'm going to tell you first about the data from Botswana. And the 2 sites are actually very different in terms of the patient population that they see. In Botswana, we're working at a PEPFAR-funded clinic, so all of the women who come to this clinic are HIV positive. And in this setting, the incidence of high-grade precancers is very, very high, much higher than you might see in a setting that has a lower incidence of HIV. And so we went in and we asked the physician that we were working with to place the probe on a site that appeared normal to her and a site that appeared abnormal to her. We took our images and then she biopsied those two sites. And I'm going to show you data from a study where we imaged about 45 different sites, about half of which were normal to her eye, and about half of which were abnormal to her eye. And you can see that the high-grade precancerous lesions, those are the CIN2s and 3s, that's about a third of our data set in this case. The reason it's so high is because this is a very high-risk setting. So what did we see? Well, along the top row, you see here's an image of the cervix. Here's where the probe was placed. It's a normal appearing area. Here's the image from our microscope. Small nuclei, evenly spaced. Here's the biopsy, showed normal cervical epithelium. In contrast, here's a lesion on the cervix right here. Here's the image from our microscope. The nuclei are larger, they're much more crowded, and that agrees quite nicely with the biopsy, which showed a CIN3 lesion. So in this case, we get very nice agreement. Now, what we were really interested in this study was those things that look abnormal to her eye, but are actually histologically normal, those false positives that are the problem for VIA. So here's that lesion that I showed you earlier, which was a false positive, and here's the histology that shows it's normal, and here's the image that we obtained with our microscope. Again, nuclei are small, evenly spaced, very characteristic of what we see in normal tissue. And so we wrote some software to automate calculating the size of the nucleus and the nuclear to cytoplasmic ratio. And what we found in that study was that there were statistically significant increases as we moved from things that were histologically normal to low-grade precancer to high-grade precancer. We were seeing an increase, and it's very consistent with the magnitude of the increase that pathologists see when they look at these same histology slides. Now, there are differences on average. Can we use that information, though, to have diagnostic accuracy? So here I show you for all of the 44 samples in that study, what was the nuclear to cytoplasmic ratio versus the histologic diagnosis. The dots that are colored black are high-grade precancers. Those that are in gray are low-grade precancers, and the white ones are histologically normal samples. And you can see that a very simple threshold does a great job of helping us separate out those high-grade lesions. And if we look at a receiver-operator characteristic curve where we trade off the sensitivity versus the specificity, you can see that we have good sensitivity as well as good specificity, and we do better than the clinical impression, which is shown right there. We do better in terms of specificity and sensitivity than just visually looking at these lesions. Now, that's a very small pilot study done in a very high prevalence setting. So our next step was to do a larger study in a lower prevalence setting. And for this, we worked with Phil Castle, previously of NCI, and now at ASCP. And we piggybacked on a very large study that was going on in China to look at VIA and HPV DNA testing, and we were able in a subset of that study also to do our high-resolution imaging. So in the big study, they had 2,500 women in rural China. They all had visual inspection with acetic acid. And about 4% of those women had an abnormal visual inspection with acetic acid exam. All of those women we did high-resolution imaging in. About 96%, about 2,400 women had a perfectly normal exam by VIA. About 100 of them, 111, were randomly selected, and we also did high-resolution imaging in those women who had a normal VIA. So going into our study for high-resolution imaging, we had 174 women. They all had an HPV DNA test, they all had VIA, they all had colposcopy, and we biopsied anything that looked abnormal by colposcopy. And so in the end, we imaged about 160 sites. I have biopsies from about half of those sites. very similar results. On the top row, you can see here's a photo of the cervix. This is the probe in contact with the cervix. That's an area, it was abnormal by visual inspection, but it was normal by our imaging, and it was also normal by histology. Here's another site on the bottom row. It was abnormal by visual inspection, abnormal by high-resolution imaging. This was a high-grade precancer, a CIN3. And I want to show you, we get images at video rate with this technology, and you can actually map out very precisely lesion borders. So in this video, the probe starts out on an abnormal region, and you can see it moves to the border right here between a region of high-grade disease and a region which appears to be very normal based on the nuclear to cytoplasmic ratio. And what we found is that the nurses who are actually placing the probe are easily able to interpret the images based on just visual inspection. Now, like we did in Botswana, we analyzed the images quantitatively, and we looked at the nuclear to cytoplasmic area ratio. And in this study, we had a lot of sites which were visually normal, as well as sites which were visually abnormal, but histologically normal. And it's interesting, the visually normal sites have the lowest NC ratio. Then as we move up to the visually abnormal but histologically normal sites, things like inflammation, other benign lesions like metaplasia, the nuclear to cytoplasmic ratio goes up somewhat. But when we get over here to the high-grade precancers, the CIN2, the CIN3, and we actually had 2 women with cancer in this study, you see that the nuclear to cytoplasmic ratio goes up significantly. Now, can we use that diagnostically? We've looked at that in 2 ways. The first way that we looked at that was we looked at just the women where we had biopsies. So these are all the things that visually appeared abnormal. And they're coded by histology. So the black dots are high-grade precancer or cancer, and the white dots are things that were normal or benign. And you can see again, just a simple cutoff does a pretty good job of catching all of the high grades and the cancers. We still catch some of those things that were visually normal, but we can reduce by about 2/3 what would have been unnecessary biopsies or unnecessary treatments. And if we look at the things that were visually normal, I don't have biopsies in these, but they were visually normal, you can see that almost all of those were normal by our microendoscopic imaging. So if we just look at the fraction of lesions that were positive by high-resolution imaging, if it was visually normal, less than 10% of it was abnormal by high-resolution imaging. If it was visually abnormal but histologically normal, about 1/3 of it was abnormal by our imaging technology. And if it was high-grade precancer or cancer, they were all positive by the high-resolution imaging. Now, the current device that we use both in Botswana and in China relies on a laptop to control the system and to display the images, and that is obviously impractical for wider scale screening. And so we're looking at how we can leverage consumer electronics to eliminate the need for the computer to control the system. And it turns out, actually, you can use a variety of different consumer-grade cameras. So we've used a digital SLR camera. You can see the fiber probe coming off the front of the digital SLR. And here's an image of the cervix that was obtained in vivo using this camera, and then you can just use the display on the back of the camera. Or you can use a cell phone camera. Here's images. You can see this is actually an image of the oral cavity from one of the students in our lab on the screen of the iPhone here, and you can display that in real time as well. So it's definitely possible to scale down the size of these imaging devices and leverage off of the mass market that exists for these consumer electronic devices to bring prices down. Now, I want to talk about 2 other types of cancers that are important both in the developed world and in the developing world. And the next one I want to talk about is oral cancer. Oral cancer is a great example of, again, an organ site where if we can achieve oral detection, patients benefit greatly. But unlike cervical cancer, where we actually have good screening tools that are used in the developed world, we really don't have good screening tools in the developed world or in the developing world. And the incidence of oral cancer is very, very high in India, in Taiwan, in the United States, in settings where people use tobacco or other tobacco-related products. They expose the mucosa of the oral cavity to carcinogens, and there can be a very high incidence of oral cancer in these settings. So here's a clinical photo. The standard of care right now to screen for oral cancer is visual examination and palpation by white light. So where's the lesion? It was easy to see the lesion on the cervix after you put acetic acid. It's a lot harder to find the lesion here by white light examination. So we have been working to develop what we call multimodal imaging, where we combine imaging with a large field of view, but do it in a way to help improve the contrast between precancerous areas and normal tissue to help guide then the placement of high resolution imaging systems. And so let me show you now that same image. The white light image is repeated there on the left, and on the right, we're imaging the autofluorescence of the tissue. And you can see that the area where the lesion is shows a very distinctive loss of autofluorescence right here, and also a little bit more over here. But you really can enhance the contrast between the precancerous tissue and the surrounding normal region by tuning the properties of your illumination and by choosing the illumination modality appropriately. And so in collaboration with MD Anderson Cancer Center, our group did a very large study where we looked at a wide variety of illumination modalities and conditions and determined which conditions gave you the best contrast. And basically we found that doing autofluorescence imaging with blue illumination at 405 nanometer illumination gave us the best contrast between precancerous lesions and surrounding normal tissue. And in a validation set, we got nice sensitivity, 94%, specificity of 86%. We'd like to see that be a little bit higher. We built a version of that device that in collaboration with Tata Memorial Hospital in Mumbai, India, we were able to trial in their oral cancer prevention clinic and found very similar sensitivity and specificity using a completely different device in a completely different setting. We were able to validate the same sensitivity and specificity. And that technology actually was licensed to industry. It's been commercialized by a company called Remicam. And a colleague of mine at the UT Dental branch is an oral pathologist, and he has been using that commercially approved device to do screening in a low prevalence setting. And I want to show you some results from 3 of his patients to illustrate both the success of that approach and the continuing challenge of that approach. So we've got on the top row here white light images from 2 patients in his clinic. In the middle row, fluorescence images from those same patients, and on the bottom, the histology. And so let's start with the patient over here on the right. There's 2 little exophytic lesions in the white light image, but you see they retain their fluorescence. He went ahead and biopsied them, and they just showed focal reactive hyperplasia, totally benign finding. So the fluorescence helped to show that they retained their fluorescence, they weren't of concern. Over here, the patient on the left, you can see there's a little lesion right here. It was actually identified by a dental student who called him in. They did fluorescence. They showed an area of loss of fluorescence in the fluorescence exam. They biopsied it, and it was a submucosal cancer that would have been missed otherwise on the white light exam. So that is one of the things we're hoping to achieve, obviously improve the sensitivity of detection. But here's the big challenge, and this is important in the developed world, and it's especially important in the developing world. Here's a lesion. It's not hard to see this one on white light. Look at the loss of fluorescence. They biopsied it. It's inflammation. It's a false positive. And so there's a lot of controversy. There's another device called the Velscope, which is commercially available for doing autofluorescence imaging in the oral cavity. And there's a lot of controversy about whether devices like this are going to lead to a wave of expensive and unnecessary biopsies of benign lesions. So in multimodal imaging, what we want to do is use the wide field imaging to help us recognize these suspicious areas, but then go in with hopefully higher spatial resolution and higher specificity to figure out, is there really a lesion there? And so we've been doing that in the oral cavity. So here are 2 patients, white light and fluorescence. And let's look at the patient on the top. So you can see here's the lesion. There's loss of fluorescence. We put our probe here on a normal area. Very nice, high resolution imaging, small, evenly spaced nuclei, very consistent with the histology, which shows normal tissue. Here's another patient. Here's the lesion, loss of fluorescence. We place the probe, and large nuclei agrees well with the diagnosis of severe dysplasia. But what about when we get fooled by the wide field imaging? Here's a lesion. The lesion is right here. It shows loss of fluorescence. We put our probe on that area. The nuclei are small and evenly spaced. It agrees very nicely with the histology that just shows inflammation. So we were encouraged that this might be able to help us rescue a little bit the specificity of the wide field imaging. The final patient that I want to show, this is now that patient that I showed you at the very beginning. We looked at the white light image of this patient. So here's the white light image. Here's the area that showed loss of fluorescence. And we put our probe on two different areas here. The first area, the nuclei are small. The biopsy showed normal tissue. Second area, nuclei are enlarged. The biopsy showed moderate dysplasia. And we have just completed a series of 30 patients where we imaged and biopsied 83 different sites. And if we combine that information from the wide field imaging together with the high resolution imaging, we find we get very, very good sensitivity and specificity, and that together the two technologies perform better than either one alone. And so that's the direction that we're pursuing. In the case of the cervix, we've got the wide field results with the visual inspection with acetic acid. There's not a need for another wide field imaging technology. But in the case of the oral cavity, we really need some adjuncts to improve visual examination. In both cases, the high resolution imaging can help us improve our specificity. So the final cancer that I want to just talk very briefly about is esophageal cancer. And esophageal cancer is another good example of a cancer where we just don't have good screening tools. Right now, the 5-year survival rate overall for esophageal cancer, it's a dismal 15%. And it's because patients who are diagnosed with esophageal cancer tend to get diagnosed at a very late stage, no matter where they live. Again, we need better screening tools, both in the developed and in the developing worlds. And so I have a collaboration. It's a joint collaboration with Mount Sinai in New York and Jilin University Hospital in China. Both settings where endoscopy is available, because to access the esophagus, we have to go in via an endoscope. But even with endoscopic screening, what they're finding is in patients who are at risk, they're missing about half of the potentially diagnosable precancerous lesions. So we took our high-resolution imaging system. This photo was taken in China. And you can see here's the high-resolution microscope over on a cart here, and we're introducing the probe through the biopsy channel of the endoscope. Esophageal cancer is really interesting. There are two types of esophageal cancer: squamous cell cancer, which is more prevalent in China, and adenocarcinoma, which is more prevalent in the United States. So I'm going to show you some data from China. And what we're finding in the China study is that the endoscopists really want to be able to make a visual diagnosis as they're placing the probe on the mucosa of the esophagus. And we've tried a lot of different ways to present the data to them to help them make this visual diagnosis. And in the end, we found a very simple approach that resulted in their accuracy being just the same as our quantitative image analysis. And that is to superimpose a grid on top of the image with a spacing that corresponds to the average intercellular spacing that we measure in normal tissue. And to put dots along the top of the image, here you see 5 dots that correspond to the size of the nucleus in normal tissue. And so they look at these dots as a size guide, they look at the grid as a size guide, and they judge the nuclear size and the nuclear spacing relative to the grid and the dots. And it really has proven to be quite helpful, particularly to discriminate benign lesions like inflammation from things like moderate dysplasia and cancer. The things on the top should be considered normal here. The things on the bottom should be considered concerning and of risk. And using that approach, we're getting very nice sensitivity, specificity, and importantly, very good negative predictive value to give them confidence if they call it normal, that they could skip a biopsy and not be worried that they were going to miss something. So I just want to say a few things in conclusion. I have a big focus in my lab through the imaging work that we do on translational research and putting students in the clinic to work with oncologists, to work with surgeons, to make sure that the tools they develop meet the needs that people face in their clinical practice. But I think if we want to develop technologies that will make a difference in cancer morbidity and mortality globally, we need to make sure that those students are seeing the challenge not just from the perspective of the developed world, but also from the perspective of the developing world, to make sure that the whole world is visible to them. And that in that context, as they are developing new technologies, they're not just making expensive technology that is impractical for settings where they're most needed. They really are focused on developing the right kind of technology to get the job done. Because there's plenty of data to show that cost-effective strategies do have global benefit. What does it take to make that happen? I think there's a really big need for long-term collaborative research partners that improve patient care at the same time the research is ongoing. I think that's an absolute must. We need more large-scale multi-center trials, especially in low prevalence populations. When we're looking at small series and high prevalence populations, we're not getting enough data from the lesions that cause problems, the false positives. And at least in the case of cervical cancer, the incidence of inflammation is so much greater in the developing world than what we see in the developed world. We're not really seeing the challenge unless we're doing those kind of trials. I think one of the biggest challenges is how do you do that and get good pathologic endpoints? So our trial in Botswana is a country of 2 million people. In the entire country, there are 2 pathologists. They do everything. They do autopsies, they do all the surgical pathology, everything. So getting the biopsies read for our clinical trial, it's not the highest priority. They're very, very busy people. So we need to have this information, but we need to be helping to build the capacity to be able to get this kind of information, not just for the research, but also for clinical care. And then I think in terms of the imaging, we have to focus more on the benign conditions that can result in poor performance as we move to the community. And I think the last challenge is how do we commercialize this in a way that makes sure that the technologies are affordable and available where they are most needed. So let me stop there. I want to acknowledge the people in my group at the University of Botswana, at MD Anderson Cancer Center, Mount Sinai School of Medicine, Gillian University, Tata Memorial Hospital, and the NCI that participated. And I'd be happy to take any questions. Thank you.
Thank you for a wonderful talk. Any questions?
The inflammation seems to be a major issue. In the cervix, are a lot of those sexually transmitted diseases that could be perhaps screened at the same time?
Absolutely.
Well?
There's no question that they should be screened and they should be treated at the same time, and that is primarily why you see that big increase.
But I gather you have the same problem in the oral cavity as well. And is that inflammation associated with infection, or is it more from other irritants?
I don't think you could attribute it primarily to one cause. We see a lot of different reasons for that inflammation. In some cases, it's scar tissue. You see cheek bite lesions. In some cases, it's related to PON use. It's a whole spectrum of things.
Any questions? Maybe I can ask. I really like this effective solution. Is there any need more spectroscopic information to analyze more in the deeper?
Yeah. So we've looked a lot at whether additional spectroscopic information could help improve the sensitivity and specificity. And I think the answer, somewhat surprisingly, is that once you get beyond 2 to 3 wavelengths of information, it doesn't seem to help you a whole lot. And the thing that surprised me the most is the reaction that we got from our clinical colleagues when they're able to see images that look like what they're used to seeing through the microscope, that they have a lot more confidence in the technology, that it's measuring something that is biologically sensible. And so there's been much more rapid uptake when we can show those kind of images. It surprised me.
Great.
So up here, hi, way up here.
Up here.
Hi. There's some really amazing technology that's coming out of your lab. What, in your experience so far, are the barriers to commercialization for low resource settings? Does it have to be set up and commercialized? Can you go through an NGO? Can you go through like Kickstart or something like that? Like, what is actually possible to get this set up to get it out into the field?
So I wish I knew the answer to your question. I mean, I spend so much time thinking about that question, and I think many of the people in this field spend a lot of time thinking about it. I think the answer is different when you have dual use technology than when you have a technology which really is only needed in the developing world. And so in my experience, it's been a lot easier to get companies interested when there is a dual market. And it has not been as challenging as I thought it might be to negotiate license agreements with preferred pricing and guaranteed manufacturing for the developing world in those cases. My experience has been it's a little bit more challenging when there is only a market in the developing world and you're looking at a complicated regulatory pathway for that technology. There are more uncertainties, and I think people are trying all the kinds of things that you mentioned, partnering with NGOs, doing nonprofits, doing low-profit companies. I think the one area where I have seen a lot of development in the last few years is looking at middle-income customers in emerging economies, like in Brazil, in China, in India. I see more industrial investment in that area. I'm still not seeing a huge amount in sub-Saharan Africa, so I think it's an area that needs a lot of attention. Okay.
So it would seem that your technology is dependent on having intact epithelium to determine, what about those lesions that are ulcerative?
Yeah, so when you have an ulcerative lesion, you basically get an image of the stroma, and you can see stromal fibers. And the challenge there is differentiating it from a cancer, because with a cancer, you also have stroma intermixed with epithelium. We have a relatively limited amount of data, so I'm hesitant to say, I don't think we have enough data to say with what sensitivity and specificity we could discriminate between an ulcerative lesion and an ulcerating cancer. They share many similar features, unfortunately. Our focus has been much more, though, on trying to identify the early lesions where you are more likely to have an intact epithelium.
Any more questions? If not, let's thanks to Rebecca again for her wonderful talk. Thank you.